Good afternoon, everybody, my dear teachers and everybody. I'm Dr. Shruti, and I'll be presenting today a very scary topic, unusual complications of central venous SS. So we all know the SS sites, particularly three SS sites, the IJV, the subclavian vein, and the femoral vein. And at the end of this, we'll come to know that none of them are safe, actually, which we consider to be safe. So we'll be talking it through some case presentations. The first case being a 17-year-old male. He had a history of idiopathic scoliosis and he was brought for posterior finals fusion. Like in all big surgeries, he underwent the internal jugular cannulation, which failed, and then they went for a subclavian cannulation. Apart from this, the rest of the next 24 hours was uncomplicated and normal. 24 hours later, this child, he started to develop lowering of mentation, and he started to develop an obtended state with required respiratory support. CT scan showed cerebral edema and hydrocephalus, and they rightly put a ventriculostomy to reveal the hydrocephalic features. The 17-year-old male didn't revive, and the MRI showed severe cerebral edema, and unfortunately, he died on that very day. The diagnosis was made on post-mortem basis, where they found that the internal vertebral artery, which was there, the vertebral artery had been injured, which had resulted in severe vertebral thrombosis, which had resulted in stroke, and that had resulted in all these complications. So ICU catheterization, one of the inherent and rare complications is vertebral artery injuries. This occurs when the needle is directed lateral and more deeper than is required, and especially if you're not using an USG. The scary part is the signs and symptoms are typically delayed, as in this case scenario. The next case scenario is talking about a fatal atrial perforation. We had a 54-year-old male. He had end-stage renal disease and a dialysis catheter in situ. Then after 1 month, he presented to the emergency stating that his dialysis catheter is not working. A chest x-ray was done, and as we can see from here, the chest x-ray is totally fine and the catheter is rightly placed in the right place. But fortunately, they did a venography. The venography showed these features. There is extravasation of the dye into the pericardial space, showing that the catheter had come out in the pericardial space. After venography, he started presenting with features of cardiac tamponade because of the dye that had been pushed into that pericardial space. He was rushed for an emergency thoracotomy, and his life was saved for a change. So cardiac perforation are rare, but a life-threatening condition can occur. You can either present with cardiac tamponade or with mediastinitis, depending on where you are injuring the vessel. It can be high up in the SVC, resulting in hemomediastinum or mediastinitis, or it can be lowered out, resulting in cardiac tamponade. The scary part, again, it will present late because RA, SVC, IJV, they are all low pressure zones, and you can always come with a late onset cardiac tamponade, which is easy to miss. The next is about a tension chylothorax. This is more commonly which we see. In this case, we had a 58-year-old woman, and she also had a permanent catheter implantation. After that, she developed progressive respiratory distress. The chest x-ray is showing pleural effusion, massive pleural effusion on the right-hand side. In this case, it was easier to manage. They did an aspirate. They found out it was a chylous fluid. They put in a pigtail catheter, and rightly on the post of 8th day, the patient was discharged well and healthy. The next case presentation is cerebral air embolism. We all know that central venous catheterization is always a potential site for air embolism, which we tend to ignore a lot. This was 56-year-old male, and he underwent a IJV cannulation again for some of his conditions. But this presentation was after the cannula was removed. In his case, the IJV cannula was removed in a reverse Trendelenburg position, when we are continuously said that always put the patient in a head-down position, which was not done. From the CT scan, we can see that the red dots over here are showing the air into the cerebral venous system. He also underwent a CT angio. You can rightly see it over here. This is the subcutaneous tract where the air had entered. The air is now into the jugular venous system, and then it is into the vertebral venous system, due to which this patient presented with decreased consciousness, required intubation, and later he was extubated and sent home again. So we don't follow the dictums, this is what happens. Cerebral air embolism, as I said, can occur at any time when a CVC is placed. So please stick to the old age dictums that has been kept in place. Head down means head down, not a reverse Tendelbank position. Now we come to femoral venous catheter. This long we are talking about IJV. Femoral venous catheterization is done because we all think it is the safer route. No hemomediastinum, no mediastinum, no hemothorax, no pneumothorax, etc., etc. But we are coming to a case where they had put a femoral venous catheter in a 48 years old woman. She had presented with hyperkalemia because her arteriovenous graft was not working. So as an emergency, they placed a femoral venous for dialysis to go on. But after the femoral venous catheterization, the moment she was put on dialysis, she developed hypotension. The first DD that comes to mind is anaphylactic reaction, hemorrhagic shock, etc., etc. So what they did next time when they couldn't correct it by the conventional methods, they did a digital subtraction angiography. And as you can see, the dye which is coming out of the femoral vein is extravasating out of this lumbar vein over here, the anterior lumbar vein. The important point over here is we usually do an X-ray after any central venous cannulation, also in femoral. But if you punctured the lumbar vein is sitting just behind the IVC. So simple X-ray is not going to point it out. Venography or angiography is the only way you can be sure where your catheter tip is. This patient had an immediate balloon catheter compression and his life was saved. We have another case report of femoral venous cannulation. What they did was, in an emergency in a road traffic accident, they placed a femoral vein without ultrasound guidance. Now, some aspirate was definitely coming, and they kept the femoral line in situ, and for 48 hours, they kept on infusing fluids and parenteral nutrition through it. 48 hours later, they found that the woman started having abdominal distension, and she had features of multi-organ failure and features of abdominal compartment syndrome. Rightly, they placed it for emergency laparotomy, suspecting the syndrome maybe because of some RTA features as well. But they also did an on-table intravenous contract angiography. And as we can see from the catheter tip, the entire dye is extravasating into the peritoneum. Now, there has been case reports previously where the femoral vein has been punctured and the catheter is in the peritoneum. But it presenting with frank abdominal compartment syndrome is very rare. So even if you're placing a femoral catheter and your patient is developing hypertension or any other features, the take-home message is X-ray is not diagnostic here. Venography or angiography is the only way to do it. Next, we have a very interesting presentation, The Secret Life of a Lost Guide Wire. Now, what happened, a 50-year-old woman, she one day presented to the emergency complaining she is having sharp chest pain, she is having back pain, and she is having bruising. Very simple complaints, not that much complicated. On examination, they found that there was bruising behind the right, below the left clavicle, There was swelling in the right lower back, and these two swellings were visibly moving with each and every heartbeat. When they palpated this swelling, they could palpate a wire underneath these swellings. So when they took the history, they found that in 2008, she was admitted for septic shock, for which she underwent a central venous catheter by a femoral vein. A part of the guide wire was lost then, which was not found, and now she presented with this. So when they did a CT scan, this is what they found. This is a very complicated CT scan. We are seeing a part of the guide wire, which is from the IVC going into the right atrium. From the right atrium, it has crossed over to the left atrium. Part of it is still in the right ventricle. So let me tell you where and how this guide wire went. In the last 15 years, this guide wire fragmented into 3 parts. It was in the right atrium. This patient had a patent foramen ovale. From the right atrium, it reached the left atrium. From the left atrium, it reached the pulmonary vein. And that is why she was having that bruising under the clavicle. Another fragment from the right atrium went to the right ventricle. From there, it passed out of the pericardium to the anterior mediastinum, and then behind the diaphragm to the back. That was another wire. And there was another wire in the IVC as well. So this is the anterior mediastinal wire that I was talking about. And this is the one which was sitting in the IVC. She was sent to the CTVS department immediately, and then they were able to retrieve all of these wires, and her life was saved. The take-home message from all this is that these are few. Is what I want to point out is our conventional means may not always carry. A simple X-ray may not always hold. So whatever the other backups are there, we have to keep in mind as per the institute. Always use an USG for the puncture. After a USG puncture, we usually do not check where the guide wire is going. The only way you can check where the guide wire is going is through a fluoroscopy. So a fluoroscopy is always good. And the next way to confirm the tick position is an echocardiography, exactly where it is sitting. And if you have lost a guide wire, be careful. It can come to haunt you even after 15 years. So thank you.